Welcome, everybody. We're going to continue our discussion about the nurse-patient relationship, but this time we're going to focus on individual variations in drug response. For our objectives, we're going to really talk about the fundamental concepts underlying a holistic approach to patient care and how it relates to pharmacotherapy. We're going to look at psychosocial, culture, ethnicity, community and environmental factors, and then we're going to talk about genetics, ethnicities, and genders, and how this all plays into medication treatments for our clients and how those things can influence that treatment. When we're thinking about pharm, we really need to take a holistic approach. And what that means is we need to think about the biological, psychosocial, cultural. We need to think about communication and how we communicate. A holistic approach and a holistic client, that is the whole person. Now, this has a profound impact with patients and their drug response as an individual. And for you as nurses, it takes a required effort, very conscious effort to make sure that you are addressing all of the needs for your clients. There's many risk factors that can influence outcomes with a client's pharmacological treatment, and I've listed many on this slide. We're going to talk a little bit more in depth about a few of them. But you need to know for pharmacotherapy to be successful, the nurse must consider psychosocial elements, cultural, environmental, and biological variables that can affect drug response. Psychosocial can be defined as one's physiological or psychological, development in the context of one's social environment. There can be some concerns when illness starts to threaten health. And what you need to think about when you're thinking psychosocial is a perception of overall ill health, how people feel about that and believe, suffering, loneliness, despair, death. All of these can have a psychosocial impact. When you're looking at spiritual or religious aspects or influence, you need to consider what that means. So some words that come to mind are how do um, individuals perceive meaning? What do they value? Do they have hope? Do they have the capacity to love, to give, and to forgive? Do they have compassion and empathy? Does that play into their spirituality or their religious preferences? When you're looking at all of that, you need to talk to your patients and really have conversation about what is very important to them. So in a previous presentation, we talked about compliance, and I think we talked about it in the term of non-compliance as far as a nursing diagnostic statement. But drug compliance, this plays when a patient believes treatment is important and beneficial, it ends to be more effective. Um, Compliance can be issued by a couple of things. Their past experiences with medications. For example, I've taken that medication before and it made me feel so horrible. Now you've prescribed it for me again. I'm not taking that. Um, Acceptability of taking medications in a social environment. Well, maybe I don't want to take medications out in public. I don't want people to know I'm taking medications for whatever reason. You can think about that. Stigmas of certain drugs. If I'm a client that has PTSD and I've been in the military, and we've kind of done a lot of research on this and we're trying to get away from it, but there used to be a stigma with PTSD. Soldiers didn't want to be diagnosed with that. Well, if they have that thought, that's their belief, they're not going to want to take their prescriptions or let anybody know about it because somebody may think less of them. And that used to be a very prominent thought process. A person's own attitude towards their own health. No, I've been healthy as a horse my whole life. I know the doctor says I need this prescription, but I'm good. I don't think I need that. I grew up my whole life. My daddy said we don't need those medications. I mean, that could come into place. Patients may actually tell you, their attitude about their health or how they grew up could factor in. Ultimately, also a patient's expectations. Maybe I've been prescribed a medication before and I thought it was going to fix everything and make me better. Maybe it's a long-term medication regimen that is not going to cure you, but it's going to keep you well so that you can enjoy life and have a good state of being. And I hope when I'm talking to you, what may be coming to your mind would be a client may be diagnosed with HIV and is on antiretroviral therapy. This is a lifelong medication process that they're going to do. And they may not want to, it takes a commitment, and they may know the medications aren't going to cure me, but they will make me feel better or help me be well. Ethnicity is biologic and genetic similarities, whereas culture is a set of belief, values, and norms that provide meaning to an individual or a group. They both have an influence on medication outcomes. When you're considering cultural competence, this is the ability to provide care to people with diverse values, beliefs, behaviors, including the ability to adapt your delivery of care to meet the needs of those patients. When you're thinking about cultural competence and you're adapting your delivery of care, you want to think about things like dietary consideration, alternative therapies, and the beliefs about their health and disease, just to name a few. So I want to give you an example. When I was nursing in Florida, when I was in Kissimmee, and there was a very high population of Indian, I believe Eastern Indian, and I wasn't very familiar with the culture. So here I go, walking into the rooms, going to give my meds, and the patient was just so upset with me, and I just couldn't understand why he was so upset. I was coming to give him his medications. What I ended up finding out is that the time that I would do my afternoon medication pass around the 3 or 4 o'clock time frame was the time that that particular culture used to pray. And when I would walk into the door, I was disrupting what they needed to do. So once I learned that, of course, that did not happen again, but I had to take some time and really learn about the culture in which I served, because this was a completely different area for me. So if you're going to move out of your geographic area where you've been learning, move to another state, move to another county, because it can be different from county to county here in our area. Take time to learn the individuals that you serve. So I've posed for you a list of community and environmental influences. Not going to speak to each and every one of them. I think you can understand, population growth and industrial growth and population density and possibly how they can play in. But I picked those three because I want to drive you down to access to healthcare. If you think about population growth, density, more people in one given area, or maybe even less in a rural community, how does that drive access to healthcare? And what influence does that have? Well, that drives us right about to healthcare systems, and we're talking, think about inadequate healthcare insurance, cost of drugs and treatments, and then limited medical care, especially in the rural areas. And there's even some places where there's so much population overgrowth that there could not be enough services to go around and serve everybody. So I want you to just take some time, look at this slide, look at each and every item, and kind of give yourself an example of what each of these are and how they can affect your patient. So illiteracy, I think we've been talking along the past couple presentations, and we always get to teaching, and I've been trying to be very adamant about deliver your patient education to the level of the patient, and this is kind of where illiteracy comes in. You need to think about it, what that really means to you, and then with each and every patient you care for, what does that mean to them? Because it may not be the same thing. Um, Generally, there's a significant percentage of English-speaking population that is functionally illiterate. Now that's interesting. I'm functionally illiterate. That can happen. Many can't read the drug labels. Not all, but some. They may not understand written treatment instructions. You know, all that wonderful teaching you're doing about their diagnoses, all this wonderful education you're going to give them about their new medication. They may not be able to read the handout or brochure you give them. This is all going to tie into them not understanding or can prevent them from understanding the true importance of their pharmacotherapy and the medications that they're offered. So nurses, in your practice, you need to make every effort to educate your patients who are illiterate or who speak a foreign language. So you kind of got to dive into their world. I want you to know nursing is up close and personal. Sometimes you have to ask some questions and you have to have conversation to find out really what level are they on, either with reading, understanding, or anything, so that you can provide the best education, which will provide the best outcome, hopefully, for your clients. Genetics, ethnicities, and genders can influence how medications work with individuals. You need to consider the client family history as it relates to genetics. We know that there's a connection with disease processes, if there's a history of a disease process or maybe some genetic factors, but this can also play in with medications. Consider cultural competency as it relates to different ethnicities, and you need to be aware that certain ethnic groups are more prone to diseases and the medications used to treat them. So I'll give you an example. Now I want you to think about this. If I ask you, if you were to tell me one ethnicity that is at higher risk for some comorbid conditions, and I'll just give them to you: diabetes, hypertension, and high lipids, high triglycerides, what would you say? Hope your brain is thinking African American, because they do. They have a higher propensity, and they're not the only ones, Native Americans too. Now, take hypertension. If I were to ask you what medication with a certain ethnic group has known problems with ACE inhibitors, you might be like, well, I don't know that yet. We haven't learned that one just yet, but I'll tell you. African Americans. So here we have a population that is at a higher incidence of hypertension. One of the primary meds used to treat it, an ACE inhibitor, like the lisinopril, is given, but we need to know that African Americans typically have signs and symptoms and adverse effects with that. So they may be started on a different antihypertensive. Um, Gender can also affect treatment. So, for example, women may seek health care earlier than males. Now, you know this isn't hard set in stone, but sometimes they'll go more frequently than men. Side effects of medications can also be gender specific. Responses to medications could also be due to things like body composition, blood flow, and rate of elimination of the drug. So that's just a quick overview of genetics, ethnicities, and gender. So this concludes our presentation talking about individual drug responses. If you have any questions, please post them in the appropriate prep for exam discussion forum of your Blackboard course. Thank you.